Hello, Medicos. Good day to all of you. In today's session, we are actually continuing with the year. So, in the second part of the year, our learning objectives for today will be mainly on the other aspects of the middle ear cavity. So, we had stopped with the middle ear cavity discussing the roof, floor, anterior wall and the lateral wall. So now we will be continuing in this class with the features on the posterior wall and the medial wall. Then we will actually try to understand certain aspects about the ear ossicles and then also about the mastoid antrum. Then we will pass on to the internal ear. So the parts of the bony labyrinth, membranous labyrinth, and how actually these structures are actually present in the organ of corti. And of course, I will be discussing in between the clinical aspects related to these learning objectives which we are going to discuss today. So first, let us try to have a short recap of the previous class. So the middle ear cavity, roughly cubical in shape, has got the following boundaries, mainly the roof, which is the tegmental wall, thin plate of bone, and also continues with the roof of the mastoid antrum, separates the middle ear cavity from the middle cranial fossa. Then you have the floor or the jugular wall, mainly related to the superior bulb of internal jugular vein, and the tympanic branch of the glossopharyngeal nerve enters through this wall. Then you have the anterior wall or carotid wall related to the internal carotid artery, and you see two bony canals. One is actually for the auditory tube, and other one is the canal for the tensor tympani muscle, and the caroticotympanic nerves also enter through this anterior wall. Then lateral wall we have discussed in detail about the tympanic wall, which consists of the tympanic membrane, and medial aspect of the tympanic membrane, what is attached is the handle of malleus, and what passes medial to the handle of malleus is the cauda tympani branch of the facial nerve. So then the structure of the tympanic membrane and various parts of the tympanic membrane also we have discussed in detail. Okay, so that is a very diagrammatic representation of the middle ear cavity with the roof and then the floor. You see the lateral wall, and then what you see is the medial wall, and on the other end what you see is the posterior wall. Actually the anterior wall has been removed. So the roof is actually also what happens, it extends a little above, and it is called as the epitympanic recess or epitympanum. Okay, so today this class we are mainly going to concentrate on the posterior and the medial wall. So now coming to the posterior wall of the middle ear cavity, it is actually called as the mastoid wall because it is related to the mastoid antrum and the mastoid air cells. So mainly in the upper part of the posterior wall, you see a opening which is the additus to the mastoid antrum. Okay, through this the middle ear cavity communicates with the mastoid antrum through this opening which is called as the additus or the opening to the mastoid antrum. Okay, and you know the roof of the middle ear cavity continues as the roof of the mastoid antrum also. Okay, so that is part of the mastoid air cells, and it through communicates through an opening in the upper part of the posterior wall which is called as the additus to the mastoid antrum. Then what other features you come across is the vertical part of the facial canal. Okay, so you'll be able to see the vertical part of the facial canal inside which the um, facial nerve is actually descending up to the stylomastoid foramen through which the facial nerve emerges out of the skull. So the facial canal has got a vertical part and also an oblique part which you will come across in the medial wall of the middle ear cavity. Okay, so that will be the medial wall of the middle ear cavity, which you see the impression of the oblique part of the facial canal, and this is actually the stylomastoid branch of the stylomastoid artery, which you are able to see here inside the facial canal, the vertical part of the facial canal. And you also have fossa insidious, a small depression near to the Auditory. So the short process of the incus will actually be suspended from the fossa insidious by a ligament. So that we will discuss when we actually pass on to the ear ossicles. Then you see a bony projection which is actually called as the pyramid, and uh, it is pyramid in shape, that bony projection. It's got a small opening through which the tendon of the stapedius muscle emerges. So inside the pyramidal prominence or projection, you see the stapedius muscle, and the tendon alone comes out through a small opening, and it is actually getting inserted to the neck of the stapes bone. Okay, so inside this you have the stapedius muscle with its nerve supply, nerve to stapedius, which is again a branch from the facial nerve. So next we will actually pass on to the middle. The next wall is the medial wall or the labyrinthine wall. So that is the lateral wall which we have seen in the previous class, and it is actually closed by the tympanic membrane, anterior wall where it communicates with the auditory tube, and that is the roof. So the medial wall is labyrinthine wall because it is very much intimately related to the internal ear, and which is mainly formed by the bony labyrinth. Okay, and inside the bony labyrinth only you have the membranous labyrinth. Okay, so let us try to understand what are the features which are present on the medial wall. So on the medial wall, main feature what you see is an eminence or prominence which is called as the promontory. Okay, so this is actually called as the promontory. The bulge or the impression formed by the basal turn of the cochlea. Okay, so it is mainly formed by the basal turn of the cochlea. The cochlea forms actually 2 and 3/4 turns, so just short of the 3 turns, and the basal turn is more wide, and it produces a bulge on the what do you call, it produces a bulge on the medial wall of the middle ear. And what is ramifying on top of this promontory is these nerves, which is the tympanic branch forming the tympanic plexus. So the glossopharyngeal nerve will give the tympanic branch, and these tympanic branch will form a plexus along with the caroticotympanic nerves, which are sympathetic nerves, and ramifying over the promontory, forming the what do you call, the tympanic plexus. Then above and behind the promontory you see an opening which is called as the fenestra vestibuli or the oval window. And in the reason state, so when we mean, what we mean with respect to the reason state is that in the living state it is closed by the foot plate, that broad foot plate you are able to see, or the basal plate of the stapes closes the fenestra vestibuli. So, as like that of the fenestra vestibuli, below and behind the promontory, you see another opening which is actually called as the fenestra cochlea or the round window. Fenestra cochlea or the round window, and that will be closed by the secondary tympanic membrane. Okay, so when the sound vibrations takes place, what happens is the ear ossicles will move, and naturally due to the vibration of this foot plate of stapes, so that will create a pressure inside the internal ear, the perilymph. Okay, so whatever the pressure is created will produce a bulge, and naturally what happens is that pressure has to be equalized by here the secondary tympanic membrane, or the which is closing the round window. So when this is compressed, so naturally what happens is that pressure has to be equalized by this round window which will bulge out. and that is why it is not closed by any hard structure but only by a membranous structure. So the membrane actually bulges out when the stapes actually vibrates by its tapping action. The other features, what all you come across is the processus cochleariformis. So you see a thin bony partition between the auditory tube and the tensor tympani muscle, and that bony partition, what happens is it extends into the medial wall as the processus cochleariformis, and the tendon of the tensor tympani muscle will wind around the processus cochleariformis and gets inserted into the handle of malleus. Okay, so the handle of malleus is the place where this tensor tympani muscle will get inserted. Then behind the promontory you see another depression called as the sinus tympani, which will be mainly formed by the posterior semicircular canal. So here you are able to see the semicircular canals. So that is the anterior semicircular canal. This is the eminence formed by the lateral semicircular canal. Okay, same way the posterior semicircular canal will form an impression behind, is actually called as the sinus tympani. And what else you come across is the oblique part of the facial canal, which you are able to see, which extends backwards and downwards, and that is to be continuous with the vertical part which is seen on the posterior wall of the middle ear cavity. Okay, so most these are the features which you come across in the middle ear, medial wall of the middle ear. So the promontory and the fenestra vestibuli, the fenestra cochlea, and then sinus tympani and processus cochleariformis. Okay, and then what you see is the oblique part of the facial canal. Then coming to the ear ossicles, there are three ear ossicles: malleus, incus, and the stapes, of which the stapes is the very smallest bone in our body. And you should always remember the fact that all these three bones attain full size at birth. Okay, now first coming to the malleus, let us try to understand the parts of the malleus. It has got a round or globular head. Then you have a small constricted part called as the neck, and it is present with the three processes. So one is the handle, which we all know, the handle of the malleus. Then it has got an anterior process which is facing anteriorly, and then what you have is the lateral process. So one head with the three processes, mainly the handle, the anterior process, and the lateral process. Okay, so the head actually articulates with the incus. Okay, the head actually articulates with the incus, upper part of the incus, forming the malleoinsidial joint, and this is actually a saddle variety. So it is one of the smallest saddle joint in our body. Okay, so this is actually of the saddle variety which you are able to see here, and the head is actually present in the epitympanic recess and suspended by a ligament. Then what you see is the long handle which is attached to the medial surface of the tympanic membrane. Medial surface of the tympanic membrane, you are able to see it is attached to the fibrous layer. Okay, and what passes medial to the base of the handle is the cauda tympani nerve, and the tensor tympani muscle is attached again to the base of the handle. Okay, so the tensor tympani muscle you can see attaching to the base of the handle. And you have two more process. One is actually the anterior process, and other one is the lateral process. So this lateral process, what you are able to see here, one ligament is attached called as the anterior ligament of malleus. So that will actually pass through the petrotympanic fissure and attaches to the spine of the sphenoid. Anterior ligament of malleus. It's again considered as the upper continuation of the sphenomandibular ligament, anterior ligament. Then to the anterior process, the short anterior process, the anterior and posterior malleolar folds will be attached, and between these two folds you have the pars flaccida of the tympanic membrane. Pars flaccida. So that pars flaccida, pars tensa, all those things we are actually discussed in detail in the previous class itself with respect to the tympanic membrane. So that is the anterior process which gives attachment to the anterior and posterior malleolar folds, and between these two folds you have the pars flaccida part of the tympanic membrane. So that is about the malleus. Now we will move on to the incus. So incus presents a body, and then it has got a short process, and you're able to see that is the short process, and that is the long process of the incus bone. So the body actually maintains contact with the globular head of the malleus from the malleolo-insidial joint, and whereas the long process, and finally it forms a lenticular shaped nodule through which it articulates with the head of the stapes bone, forming the ball and socket joint. Okay, so this is actually a ball and socket variety. It is indeed the smallest ball and socket joint in the body. Okay, so then you are able to see that is the short process. The short process is attached via a ligament to the fossa insidious in the posterior wall of the middle ear cavity. So that is the posterior wall which you are seeing. In the upper part of the posterior wall, you are able to see the adductus to mastoid antrum. Okay, so that is the fossa insidious with the short process is suspended from the fossa by a ligament. Then you are able to see the stapes bone, which has got a small head, then neck, and it has got a two anterior and posterior limbs. The anterior and posterior limbs are actually attached to the foot plate. Okay, it is actually attached to the foot plate or a basal plate. So head articulates with the incus forming the ball and socket joint. Okay, and then what is attached to the neck, you are able to see from the posterior wall. You see the pyramidal eminence through which the stapedius muscle, so that is again one of the what do you call very smallest muscle, stapedius muscle, the tendon coming out of the pyramidal eminence, and it is getting attached to the neck of the stapes. Okay, so the base of the stapes closes your oval window or fenestra vestibuli. So what happens is when the sound wave impulses that travel via the external auditory meatus, that vibrates the tympanic membrane. So the handle of malleus moves medially. So when the handle of malleus is drawn medially, then naturally what happens is the malleolo-insidial joint rotates around an axis, passing from the handle to the lateral process or the short process of the incus. So when this actually moves, and that is transmitted via the movement in the insidiostapedial joint, and that actually taps the what do you call the basal plate. So the basal plate is actually moves like a foot with the heel resting, and only the front part of your toes or foot tapping. Okay, so the heel is the posterior part which is fixed, and the remaining anterior part of the base taps. So that sends a pressure into the internal ear through the actually the perilymph, and so that pressure create certain changes which we will discuss in the internal ear, and that compressed pressure what happens has is affected mainly on the round window where the uh, secondary tympanic membrane bulges. When this part is compressing the perilymph, so that compressed perilymph pressure has actually be released mainly through the what do you call the secondary tympanic membrane, which is affected there. Okay, so that is how conduction takes place. Mainly this is uh, called as the conduction through the ear ossicles. Okay, now there are actually two muscles which are present. One is the tensor tympani muscle, which you are able to see here, So it passes through the canal for tensor tympani, then winds around the cochleariformis and then gets inserted into the handle of malleus. So it draws the handle of malleus medially, and it is mainly supplied by the trunk of the mandibular nerve. So branch from the trunk of the mandibular nerve. So it mainly draws the handle medially and thereby tenses the tympanic membrane. The next muscle what you are able to see is the stapedius muscle. So the muscle arises from the pyramidal eminence and it is inserted into the neck of the stapes. So it is supplied by the branch from the facial nerve. So the main action of the stapedius is pulls the stapes laterally. So when it pulls, the tapping action will takes place as you tap your foot on the floor to a music. While the heel is rest, only your anterior part of the foot you actually tap on the ground. So the same action can be extrapolated to the action of the stapedius, the stapes bone. Now both the muscles together, what happens, dampen the sound vibrations. So this is what happens when the tympanic membrane is actually vibrating. When you inflate the tympanic cavity via the auditory tube through air or something, what happens is then the handle of malleus has to move laterally. When the handle of malleus moves laterally, the incus and the stapes does not move because the handle is actually not locked at the malleolo-insidial joint. This should not happen. If it happens, then actually if the handle moves laterally during the inflation, then the stapes will get dislodged. Okay, from the foot plate actually what happens, will get dislodged from the oval window. So the foot plate along with the ligament, annular ligament, it actually closes the oval window or the fenestra vestibuli. So coming to the clinical aspects, so hyperacusis is paralysis of stapedius muscle. So because of that, what happens is any small sound is also heard as a loud noise. So that is called as hyperacusis. So Rennie's test is mainly to diagnose conductive deafness. Because sound conduction is mainly through the ear ossicles, mainly through the air and the tympanic membrane, and also through bone conduction. So through the bone conduction only one actually hears his own voice. Okay, so to actually confirm the conductive deafness, whether the sound is conducted to the middle ear through the ear ossicles, you do this Rennie's test. You take a tuning fork and you place the tuning fork in the mastoid bone after vibrating it. So you hear the noise through the bone conduction. Now after the tuning fork, what happens, you don't hear the noise after some time. The same fork you place it in the external auditory meatus. Naturally what happens is you should be able to hear the sound because through this conduction what happens is sound vibrations through the tympanic membrane have a greater range than the bone conduction. If the ear is normal, you will be able to hear that. Otherwise, what happens is if you place it the tuning fork after through bone conduction in front of the external auditory meatus, if you are not able to hear, that confirms that there is a conductive deafness. If you are not able to hear once initially, even when it is placed on the mastoid bone, then actually there is due to deafness due to nerve conduction rather than uh, through these ear ossicles. Okay. The next test what you do is the Weber's test to differentiate the cause of deafness. So here what you do is you actually again tap the tuning fork and place it in the vertex of the skull and see whether it is heard in both the ears. Now, if it is heard better in the affected ear, then naturally what happens? It is only due to conductive deafness. Because bone conduction is actually transmitting to the affective ear. That means only there is a problem where there is a conduction of the sound waves through the middle ear. If it is heard better in the normal ear, so normal ear, if it is hearing rather than the affected ear, then it shows that the bone conduction is also not passing on to the affected ear. That means it is mainly due to the defect in the nerve, that is the cochlear nerve. So infection or inflammation of the middle ear cavity is called as otitis media. So there might be many reasons. One is mainly your nasopharynx. Infections can actually transform through the middle ear into the can actually from the nasopharynx it can actually through the auditory tube it can spread to the middle ear. Okay, more common in children. And otosclerosis is abnormal ossification of the annular ligament, which is closing the fenestra vestibule, and the foot plate of stapes related to the foot plate of stapes that leads to conductive deafness, otosclerosis. And then tinnitus is actually ringing in the ear, so that we will come when we discuss about the internal ear. Next, passing on to the other aspect, we will have a very short discussion about the mastoid antrum. So what is mastoid antrum? You are able to see uh, hair cells within the petrous part of the temporal bone, and it is also considered as the backward extension of the tympanic cavity. This antrum or space is full size at birth. So your mastoid antrum, tympanic cavity, and your ear ossicles and your bony labyrinth are all full size at birth. Now this mastoid antrum will be invaded by mastoid air cells, sprouting of the mastoid air cells, and that takes place only after birth. Okay, up to 2 years, then it is taking place. So roof is mainly continuous with the roof of the middle ear cavity, so that is the tegmental wall, and the floor is where the mastoid air cells open. So the mastoid air cells, not only it is restricted to the mastoid antrum, sometimes what happens, they might go and invade the mastoid process. That is one thing. Second thing, anteriorly the adductus to mastoid antrum. So it might also invade through the posterior root of zygoma and also along the anterior wall of the middle ear cavity. And it is posterior wall is related to the sigmoid sinus. So these air cells might also go and invade the sigmoid sinus posteriorly. Anteriorly, you see the adductus to mastoid antrum. Medial wall, you see the bulging of the lateral semicircular canal on the medial wall. Okay, lateral wall is mainly formed with the petrous part, the squamous part of the temporal bone, and on the surface projection you see the suprameatal triangle. So here that is the suprameatal triangle. The boundaries of the suprameatal triangle is mainly formed by the suprameatal crest, which corresponds with the middle cranial fossa, and then anteriorly you have the posterior superior part of the external auditory meatus, and then you draw a vertical tangent connecting this suprameatal crest and then the uh, external auditory meatus posterior superior wall. So that will form your suprameatal triangle. So that is the lateral approach to the mastoid air cells. Okay, because in case of mastoiditis, when these air cells are inflamed, they have to be removed, and that corresponds on the surface projection to this Simba concha. This is your concha and Simba concha. Deep to it, you have the suprameatal triangle. So the suprameatal triangle is the one approach to the mastoid air cells when it is actually getting when it is actually inflamed, and that condition is actually called as mastoiditis. And it might also, as I told you, spread to other areas because of the invasion of these mastoid air cells posterior to the sigmoid sinus or into the mastoid process, and through the posterior root of zygoma. As I told you, it might also enter into the anterior wall of the middle ear cavity. So that is about the mastoid antrum. Now we will actually pass on to the internal ear. So the internal ear is actually considered as one of the uh, complicated topics in anatomy. I will just try to make it as simple as possible. So parts mainly, it consists of bony labyrinth. The bony labyrinth is nothing but an intercommunicating spaces bony cavity. Inside the bony labyrinth, you see a membranous labyrinth. So membranous labyrinth is nothing but the exact replica of the bony labyrinth.
Okay, so you can consider this bony labyrinth is actually a molding or a casing, hard bony casing around the membranous labyrinth. So if you understand the bony labyrinth, then the membranous labyrinth is the same as that of the bony labyrinth. Okay, so the membranous labyrinth is filled with the endolymph and the bony labyrinth is actually filled with the perilymph. The membranous labyrinth only contains the specialized cells, mainly for the organ of hearing and also your your vestibular apparatus for your kinetic as well as your static balance. Okay, so that is mainly about a short description about the bony and the membranous labyrinth. So all this completely it is situated within the petrous part of the temporal bone. So both your middle ear cavity and also your internal ear is situated within the petrous part of the temporal bone. So parts of the bony labyrinth, as I told you, it is filled with the perilymph and externally lined by the periosteum. Okay, so coming to the parts of the bony labyrinth, they are mainly you are able to see that is the cochlea. Okay, so which resembles like the snail's shell, that is called as the cochlea. So the cochlea has got an apex and a base. Okay, so the apex is actually pointing towards the middle ear and base forms the basal turn around forms an impression over the medial wall. So it is actually situated uh, forwards and laterally. Okay, and through the base only what happens is the cochlear nerve will actually emerge from the center and it will enter the internal acoustic meatus. Then you have this part which is called as the vestibule. Okay, so inside the vestibule you have the utricule and the saccule. Okay, you have the saccule and the utricule. They are mainly for the static balance. And then the one more part what you see is the semicircular canals, which is mainly for your kinetic balance. Three semicircular canals you are able to see here. They are the anterior, posterior, and the lateral semicircular canals. And these canals open by 5 openings. Okay, so cochlea, vestibule, and then the semicircular canals are parts of the bony labyrinth. So inside also you have the cochlear duct, which is the membranous labyrinth, and the utricule and the saccule, and then you have the semicircular ducts as the part of the membranous labyrinth inside the semicircular canals. Okay, now let us go into the details of this. So first, try to understand the cochlea. It is 2 and 3/4 turns and resembles the shell of a snail, as I told you. That is the apex, and you are able to see the base. Apex is lying near to the middle ear cavity, and the basal turn produces the promontory or the bulge on the medial wall of the middle ear. So the apex is called as the cupula, and as I told you, lies near the middle ear, medial wall of the middle ear. So base is near to the internal acoustic meatus, and through the base you are able to see the vestibulocochlear nerve emerges and enters the uh, external acoustic meatus. That is the cochlear nerve. And this is your vestibular nerve, which is actually coming from the vestibule. So now we will just try to interior understand with the help of this small screw which you are able to see here. So that is the basal turn and that is the apex of the cochlea. So from extending from the base to the apex, you see a central stem that is called as the modiolus. So throughout you are able to see in the center a stem is extending that is called as the modiolus. Okay. Now around the modulus you are able to see a bony projection which is called as the spiral lamina. Okay, so that spiral lamina you are able to see when you cut inside the section. So from the base of the modulus, of course the cochlear nerve emerges, which I have already told you. So from the base to the apex you see a central stem which is called as the modulus, and around the modulus like the threading of the screw what you are able to see the spiral lamina. Okay, so The cochlea around the modulus forms a 2 3/4 turns. Okay, so that you are able to see the center modulus, and that is the spiral lamina. That is from the apex to the base. The diameter increases as you pass on to the base, and from the base of the modulus, you are able to see the cochlear nerve emerging. So these are the afferent fibers, and you see a ganglion that is called as the spiral ganglion. Okay, now the spiral lamina from the modulus, just recollect that picture of the screw is called as the spiral lamina that projects into the canal. This whole canal is actually called as the cochlear canal. Okay, now this spiral lamina does not go and touch the outer wall of the cochlear canal. So it stops in between. And what touches the lateral wall or outer edge is this membrane, which extends halfway from the uh, spiral lamina, no, the halfway from the cochlear canal to the outer wall, inner aspect of the outer wall of the cochlear canal. So you are able to see the cochlear canal, that will be the spiral lamina, and that will be the outer wall. So the basal membrane, what happens, will go and actually uh, uh, complete it. Okay, so the basal spiral lamina with the basal and the vestibular membrane. So now you are able to see that is the basal lamina, divides again into two. From here, one membrane, the vestibular membrane, goes and touches to the outer lamina. The one more membrane you are able to see, that is actually the basal membrane. So one is the vestibular membrane and one is the basal membrane. So the cochlear canal is actually divided by the spiral lamina, which comes up to the halfway, and then what is attached is the basal membrane. Okay, divides the cochlear canal into scala tympani lower part and scala vestibuli upper part. First, let us divide this into two: scala tympani lower part and scala vestibuli upper part by the basilar membrane. Then one more membrane, as I told you, the vestibular membrane, thereby divides the whole cochlear canal into three parts. That means between the basilar membrane and the what you call the vestibular membrane, you have one more compartment that is called as the scala media. Okay, so this is actually called as the scala media. In between, you are able to see that. So this scala media only is called as the cochlear uh, duct. Okay, so this is called as the cochlear duct, and inside you have the spiral organ of Corti. So this is filled with endolymph. It is a part of membranous labyrinth, whereas the scala vestibuli and scala tympani are actually filled with the perilymph. Okay, so that is actually filled with the perilymph. So when you are able to see that the cochlea, it is actually divided into upper scala vestibuli and then lower scala tympani. The spiral lamina actually extending only halfway, and that will be completed by the basilar membrane, as I told you. Okay, now the scala vestibuli, the upper compartment, if you trace it near the basal turn, it communicates with the vestibule. Okay, so actually it communicates with the vestibule. The scala vestibuli actually communicates with the vestibule, whereas if you look at the scala tympani, it is closed. So the basal lamina or the bony lamina, spiral lamina, turns downwards and then closes the scala tympani, and you have the fenestra cochlea. You're able to see, so that is the fenestra cochlea or the round window. So what happens is, so when the footplate of steps is actually vibrated, the perilymph inside this creates a pressure. That pressure travels around the scala vestibuli. Okay, and then what happens is it has to be transmitted to the scala tympani. You might ask, sir, there is a bony transmission. How it is transmitted? At the apex, the scala vestibuli and tympani communicate at the apex of the cochlea, which is called as the helicotrema. Okay, so at the helicotrema, when you see, what happens is the scala vestibuli communicates with the scala tympani. So what happens? is the pressure which is travels through the perilymph in the scala vestibuli, then it communicates uh, at the helicotrema to the scala tympani, and then it comes via the scala tympani, and that pressure you can see at bulging of the oval window, that is the secondary tympanic membrane. Okay, so in between communicating from the scala vestibuli to the scala tympani, what should happen is that vibration has to be transmitted to the cochlear duct, that is to the what do you call, the organ of corti, the organ, peripheral organ of hearing. So here vestibule communicates with the vestibule, and it presents between the cochlea in front. The vestibule is actually present sandwiched between the cochlea in front and the semicircular canals behind. Okay, so in front scala vestibule communicates with the scala vestibuli, that is present at the basal turn of the cochlea. Okay, basal turn of the cochlea. So now you are able to see that is the scala tympani, and here you are able to see the fenestra cochlea, or the round window, and one more thing you are able to see, that is the aqueduct of cochlea. So whereby the perilymph communicates with the subarachnoid space, CSF. Okay, so that is your above scala vestibuli. Okay, scala vestibuli and lower scala tympani communicates at the helicotrema, and in between what you see, that is the cochlear duct, which contains the scala media part, which contains your sensory peripheral organ of hearing. So that is the vestibule which receives the basal turn of cochlea and communicates with the scala vestibuli. And posteriorly it receives the semicircular canals. Vestibule lodges the saccule and the utricle. Next, coming posteriorly and above, as I told you, three semicircular canals open through five openings: 1, 2, 3, 4, and 5. Okay, through the five openings. Fenestra vestibuli, you can see the lateral wall of the vestibule. So what we saw is the fenestra vestibuli in the lateral wall. Medial wall contains the opening of aqueduct of vestibule. So this is actually the aqueduct of vestibule, which will have the endolymphatic duct, which is a part of membranous labyrinth. Okay, that endolymphatic duct will end in a blind saccule, endolymphatic sac or saccus. Okay, so within the medial wall, what you see is the saccule and the utricule is lodged. Hmm? Within the medial wall, the uh, utricule and the saccule is lodged, and then semicircular canals, you have anterior, posterior, and laterals, which are at right angles to each other. You know, when the semicircular canal are actually going to open into the vestibule, that is through the utricle, they show a dilatation which is called as the ampulla of semicircular canal, and inside that only you will have the specialized cells, crista ampullaris, within that. Okay, so we will come to this duct part of it in the membranous labyrinth. So now you are able to see a section of the saccule medial wall mainly consists of elliptical recess, and then you see the spherical recess. So the spherical recess will contain the saccule, and the elliptical recess will contain the utricle, where it receives the opening of the semicircular canals, and that is the aqueduct of the vestibule, through which what you see is the endolymphatic duct, which form a blind sac, which you have seen in the last section, last picture what I showed you. These perforations are mainly for the ampullary nerves. The vestibular nerves will actually, upper and lower vestibular nerves, they will unite, and they carry the sensations, equilibrium. Okay, whereas from the base of the modulus, the cochlear nerve will emerge. Both will join and emerge through the vestibulo, through the internal acoustic meatus. So that is your spherical recess, and that is your elliptical recess, which lodges your saccule and the utricule and the medial wall of the vestibule. Okay, now coming to the membranous labyrinth. So membranous labyrinth is nothing but, while the bony labyrinth is intercommunicating bony cavities, the membranous labyrinth consists of intercommunicating ducts and they are actually filled with endolymph. So mainly what you see is the cochlear duct in the scala media. You're able to see that is the cochlear duct within the bony cavity filled with the endolymph. Okay, scala media contains the cochlear duct, and inside the cochlear duct you have the peripheral organ of organ of hearing. Okay, then inside the vestibule you have the saccule in the what do you call recess, which we have seen two recess, which we have seen spherical recess and utricle in the elliptical recess. Then inside the semicircular canals you see the semicircular ducts filled with endolymph. Now the cochlear duct connects with the saccule through the ductus reunions. So this is actually called as the ductus reunions. Okay, so cochlear duct connects with the saccule through the ductus reunions. Then utricule and the saccule are connected by the utriculosaccular duct. So that is actually the utriculosaccular duct, which is Y-shaped, two limbs, and that is the stem of the Y, which continues as the ductus endolymphaticus within the aqueduct of vestibule. Okay, inside this bony aqueduct of vestibule, you see the ductus endolymphaticus and ends as a blind sac, saccus or endolymphatic sac. So, so the 3-4 turn of the cochlea duct, again it is same, follows the bony cochlear canal. Okay, so base is actually formed by the spiral lamina. So the cochlear duct base is formed by the spiral lamina and the basilar membrane. You're able to see that roof is actually formed by the vestibular membrane. So the roof is actually formed by the vestibular membrane. Lateral wall is formed by the bony cochlear canal. So inside this bony cochlear canal only, what you see, that is the peripheral organ of hearing, the organ of corti. Okay, so inside the scala media, you see the cochlear duct having this peripheral organ of corti. So mainly the cells, you come across the rod cells, and then the outer and inner hair cells, rod cells, and you have the outer and inner hair cells, and then you see some supporting cells also, and you are able to see that is the afferent fibers of the vestibular nerve. Okay, two types of fibers you are able to see that. So mainly the tunnel of corti, which consists of corticolymph, it's filled with cortilymph. It is a gap between the rod cells. Okay, it is actually a gap between the rod cells is the tunnel of corti, and here you are able to see the afferent fibers and the efferent fibers of the vestibular nerve. Then main cells, the sensory cells or the hair cells, you have the inner hair cells and the outer hair cells. They all possess stereocilia. So outer hair cells have 80 to 100 stereocilia, and inner hair cells have around 40 to 50 stereocilia. So these stereocilia will actually touch this membrane, which is called as the tectorial membrane, a gelatinous material. Now, these inner hair cells are supplied by the afferent fibers. Okay, and here also you are able to see the efferent fibers also make contact with the outer hair cells, and they all form uh, terminal synaptic butons, which will go and end in the spiral ganglion, and from there the central process starts as the cochlear nerve. Then supporting cells also you have in between, which is called as the Daters and the Hansen's cells. So that is the tectorial membrane, which is a gelatinous membrane rich in protein, more like your keratin. Keratin is hardened, but here it is protein. So when vibrations are transmitted from the scala vestibuli to this cochlear canal, so these gelatinous materials, when they touch these hair cells are stimulated, and then afferent impulses are traveled, and mainly the inner cells are concerned with the conduction, and the outer hair cells are mainly concerned with the modification of the sound, reference to the sound. Okay, so spiral ganglion is actually located in the modulus. You are able to see that. And from there, the central process starts as the cochlear nerve, whereas the peripheral process have connections with the inner and outer hair cells. Next, coming to the saccule, which you are able to see here, round membranous saccule, which is situated in the spherical recess and the anterior inferior part, connected to the cochlear duct by the ductus reunions. Then utricule is also another oblong sac. This is a small round sac, whereas this is an oblong sac. And ductus endolymphaticus is the continuation of this utriculosaccular duct, ends in a blind pouch called as the saccus endolymphaticus. So this ductus embolymphaticus is within the aqueduct of the vestibule. So now coming to the specialized sensory cells inside the semicircular ducts. You are able to see the anterior, posterior and lateral semicircular ducts inside the semicircular canals. Near to their opening into the utricle, they show a dilated end which is called as the ampulla. So this ampulla mainly consists of the crista ampullaris. So this is actually the shape of crista ampullaris. You're able to see that is actually called as the crista ampullaris. So mainly the epithelia consists of the sensory hair cells, and that is the cupula. So you're able to see. So in the cupula, into the cupula, you have the stereocilia and the kinocilia are actually projecting. Okay, stereocilia, and you have one more kinocilia. Okay, so stereocilia are more like your micro villi. So when the fluid inside the canal, so the perilymph, what happens is through that it will actually bend the cupula when you turn your head or bend your head. Okay, and that is why the cupula acts like a swing door. So it acts like a swing, so deflected to one side by the movements of the endolymph. So it mainly monitors your angular acceleration, that is rotating the head and at the same time keeping your posture upright. So when this bends, naturally these stereocilia and kinetocilia are actually stimulated, and through the afferent nerves to the vestibular nerve, what happens is it helps to maintain the posture. Okay, so that is about the crista ampullaris. Same way, you are able to see this inside the saccula and utricle, specialized cells which are actually called as the macula. Okay, so these hair cells are actually called as the sensory cells. They don't have kinocilia, but they have the stereocilia which is present, and this is actually called as the otolith. Okay, the otolith membrane mainly consists of calcium carbonate crystals. So the movement of this crystals mainly stimulates the otolith membrane, and which in turn stimulates these hair cells, and through which what happens, the nerve impulses are traveling. So this is mainly for your static movement. So when the otolith membrane calcium crystals, when they face downward by the movement of the head, naturally it gives a pull over the hair cells. So mainly the saccule is stimulated during lateral tilting of the head to the same side, whereas utricle is mainly stimulated when you move the head forward and downwards. Okay, so that is about the macula and crista, which contains the crista ampullaris. Okay, so and then what else with respect to the applied anatomy? So tinnitus is mainly ringing in the ear. So that is mainly a frequent sign of cochlear disease. So it might lead to deafness. Then vertigo is a feeling of giddiness due to sense of rotation. Is again a cardinal sign of labyrinthine dysfunction. Then motion sickness when you have excessive stimulation of utricle and saccule. So you can see when people, when they are actually ascending on a what do you call on a guard section uphill, they can see vomiting sensations. Meniere's disease is paroxysmal attacks of vertigo, tinnitus, and naturally leads to progressive uh, hearing loss. So with that, I have actually completed the internal here, and thank you very much for your patient listening.